seen in both. And it is clinically much less severe than Pelizaeus-Merzbacher disease. The most common mutation associated with this JGC2, and it affects the gap junction proteins rather than primary proteins, the primary myostructure. So in this case, other clinical feature which can be present is these patients can have additional peripheral neuropathy. And on MR, in addition to diffuse hypomyelination, we see both the ventral as well as dorsal brainstem involvement. So this is case 3, which is again a diffuse hypomyelination pattern. But here MR, I'm sorry, the arrow is little up here. It should be pointing towards this tall NA-like peak. So we discussed the causes of tall NA-like peak in the last lecture. So this is one of its cause. And at that time, yes, brilliant. So it is Sala's disease. So here what we see is there is diffuse hypomyelination, but one very specific feature is that almost always there is very much, like very significant corpus callosal atrophy. The cerebellum is relatively preserved as compared to the corpus callosum. And in addition to diffuse hypomyelination, we see a tall NA-like peak. And these patients usually they're not, it is a very not a very common disease. There are certain specific populations, for example, Finnish population, in which it is seen more. And it is a lysosomal storage disease and a secondary hypomyelinating leukodystrophy. So these patients, because it is a storage disorder, will have post faces, and we saw that the specific features are tall NA-like peak and corpus callosal atrophy. So to complete the diffuse hypomyelination pattern, I just want to tell you that there is another pattern which is not that common, but whenever we are getting a patient with Hirschsprung disease, patient is having peripheral neuropathy, Waardenburg syndrome, and along with that on brain, we see hypomyelination. So this is a case of SOX10 associated PCWH syndrome. And in this, what do we see in addition to hypomyelination? There can be associated inner ear anomalies. So whenever we are getting a case of hypomyelination with Hirschsprung disease, always try to include a 3D heavily detubated sequence in your protocol so as to rule out any inner ear anomalies. So this is the source image, and here we see in addition to the hypomyelination, there is also absence of the olfactory bulbs, and there is presence of semicircular canal dysplasia, which is a little widened as compared to the normal appearance. So the first pattern was diffuse hypomyelination. Now the second pattern is this case. So what are your views on this case? So this is a child. I'll just give a clue before that if you can crack this case. So we are seeing diffuse hypomyelination, but there is sparing of certain structures. So if you don't remember anything in hypomyelinating leukodystrophies, remember Pelizaeus-Merzbacher disease, remember Pelizaeus-Merzbacher-like disease, and remember this disease, like which can be a spotter and which can be a little common as well when we are dealing with hypomyelinating leukodystrophies. So we are seeing diffuse hypomyelination. In addition, there is sparing of certain structures. So what do you think is this structure? So this is not HEMS because we are seeing diffuse hypomyelination, not only the posterior brainstem involvement, but we are seeing diffuse involvement, but there is sparing of certain structures. HEMS rather involves only the early myelinating structures. Maybe seeing the dorsal brainstem, you thought of that. But what else it can be? There is sparing of this structure, which is optic radiation. So there is also sparing of the pyramidal tract of the internal capsule. Apart from that, there is sparing of the median lemniscus. And there is associated globus pallidus hypointensity, hypointense thalami, and there is corpus callosal atrophy. In this pattern, the clinical clue is that, so this image is not mine, taken from one of a very nice articles. So this patient has hypodontia and also has hypogonadotropic hypogonadism. So hypodontia, hypogonadotropic hypogonadism with hypomyelination. Yes, brilliant. So it is 4H syndrome. So this is polar 3 related leukodystrophy. So there can be pathogenic variants in the genes encoding RNA polymerase 3. It can be polar 3A, polar 3B, as well as polar 1C. In this case, it was polar 1C. So what do we see on MR? You have to remember is we see diffuse hypomyelination. But first of all, the clinical clue, if we get, then whenever we are thinking in terms of hypomyelination with those clinical clues, we are more likely to be sure that is polar 3 related leukodystrophy, that the clinical clues of hypodontia and hypogonadotropic hypogonadism. However, these clinical features may not always be present, and the MR features also may not always be present, but when they are present, then we can be more specific for the diagnosis. So in this case, apart from diffuse hypomyelination, there is sparing of the optic radiation, pyramidal tract of the internal posterior limb of internal capsule, and medial lemniscus. And there may or may not be, but usually it is associated with lobus pallidus hypointensity as well. So the broad classification is hypomyelination with selective white matter sparing, and there can be different clinical features, but when we get 4H syndrome, then we can be sure of the diagnosis. And usually it is accompanied by corpus callosal and also cerebellar atrophy. And apart from this broad classification, even the subunits like can have different features. There's no need to so much remember, but just for telling you that polar 3A, if it is involved, then it is corpus callosal atrophy is predominant, polar 3B, cerebellar atrophy is predominant, and polar 1C, T2 hypointensity of the substantia nigra and subthalamic nuclei are more prominent. So coming to the third, so this was the second pattern in which there was hypomyelination with selective sparing of the certain structures as we saw. Then we have another pattern when there is just selective involvement. So, any guesses for this case? So, what do we see? We do not see diffuse hypomyelination, but we are seeing hypomyelination only in certain structures. So, there is hypomyelination. So, there are white matter hyperintensities involving the pericentral white matter. There is hypomyelination involving the optic radiations, as well as there is hypomyelination involving the dorsal brainstem. So, what are your guesses about this? So what are these actually? This posterior limb of internal capsule, periatlantic white matter, and posterior dorsal brainstem. When do these structures myelinate? We already discussed. So these are early or late myelinating structures. These are early myelinating structures as we discussed. So then any guesses? So in this, there is hypomyelination only involving the early myelinating structures. So this is a case of, okay, it's not Helm, it is HEMS. So this is a case of hypomyelination of early myelinating structures. So in this also, like apart from these features that there is hypomyelination only involving the early myelinating structures, one specific pattern which can be seen in posterior limb of internal capsule is a trilaminar pattern. So in this, there are alternating hyper, hypo, and hyperintensities, so which gives a trilaminar appearance to the posterior limb of internal capsule, which is one of the features which can be seen in HEMS and can provide a clue towards the diagnosis. Now, this is another case which is taken from literature where we are seeing that the patient has cataract, and apart from diffuse hypomyelination, there is more conspicuous involvement of the periventricular white matter. So, this is a pattern which is seen in hypomyelination with congenital cataract. So, in addition to congenital cataracts, these children again have peripheral neuropathy as well. So what pattern we have to remember in this is that there is diffuse hypomyelination. In addition, there can be more conspicuous T2 hyperintensities involving the periventricular white matter. I know these are not very common cases, but we have to complete the spectrum, and these can come as spotters rarely in your exam. So today we are discussing these cases. Like previously, you were very active and you were telling all the diagnosis. So it may be difficult for to pick up these diagnoses because they all look the same. But if we know these patterns, so this can distinguish us from the others and can help us reach towards a specific diagnosis as well as guide genetic analysis. So now we are coming to the next pattern, that is hypomyelination with basal ganglia involvement. So this is first case. This is a case which can come routinely as well. So this is a common diagnosis specifically with relation to hypomyelitic leukodystrophies. So I'll tell you the findings and then you can guess the diagnosis. So in this, we have diffuse hypomyelination. And what we see is that the corpus callosum is typically preserved. So we are seeing that the signal of corpus callosum is preserved and the basal ganglia is hyperintense. So we have hypomyelination with basal ganglia involvement in the form of hyperintensity. There is, in addition, presence of T2 hypointense thalami on the ventrolateral aspects, as can be seen in storage disorders. So any guesses? So there is a clinical feature which provides a great clue for this case. But seeing the MR pattern, any guesses you have? So which hypomyelinating leukodystrophy? We are seeing T2 hypointense thalami on the ventrolateral aspect. So what do you think? It is a storage. Can it be a storage disorder? It is a storage disorder. So what do you think? With basal ganglia hyperintensity, hypomyelination, preserved corpus callosum. It is a storage disorder with cherry red spot at the macula. So what do you think about the diagnosis? Yes, Tay-Sachs, GM1, GM2, gangliosidosis. So what you have to remember in this is that in GM1, GM2 gangliosidosis, we are able to see this pattern. This is not a very rare diagnosis. So this is a common diagnosis, especially if we have the clinical clues with us. For example, cherry red spot in macula. Patient is a case of storage disorder. So we'll have hepatosplenomegaly and nephromegaly. But these patients, when it is an infantile onset GM1, GM2 gangliosidosis, usually the appearance will be like that. When it is late onset GM1, GM2 gangliosidosis, then these changes may not be seen and the white matter may be normal. So the hypomyelitic leukodystrophy in case of GM1, GM2 gangliosidosis is in case of infantile onset types. And what we see here is that we see is diffuse hypomyelination. Apart from that, we have to remember is that there is presence of hyperintense basal ganglia and the corpus callosum is almost always preserved. So this feature you should remember. So apart from in today's lecture, what we should remember is PMD, PMLD, Polar 3, and then this pattern. So at least these four patterns should be with you when you end up listening this lecture. So then there is another pattern in which there is diffuse hypomyelination. And then what do you see? So what is this is basal ganglia, and what peculiar feature you see in the basal ganglia? That will actually clinch the diagnosis. These patients usually present with dystonias, apart from the features of hypomyelitic leukodystrophies, and the dystonias are more predominant as compared to the other features of hypomyelitic leukodystrophies in these patients. Apart from this structure, there is also something here. So there is cerebellar atrophy. So in addition to cerebellar atrophy, what do we see in the basal ganglia? Do you see any signal changes or any volume loss? So there is very significant atrophy of the basal ganglia. Yes, very good. So there is a significant atrophy of the basal ganglia, and in later stages, it may appear that the putamina, especially the putamina are involved, and the putamina may be maybe looking as disappearing basal ganglia. So there is significant atrophy of basal ganglia and cerebellum, and this basal ganglia atrophy is out of proportion to the hypomyelination. So there is hypomyelination, but there is very predominant basal ganglia and cerebellar atrophy. So from as the name suggests, the can you guess the diagnosis? There is hypomyelination with atrophy of basal ganglia and cerebellum. It is actually HABC. The name itself is hypomyelination with atrophy of basal ganglia and cerebellum. So these are caused due to tubulin beta 4A gene most commonly. So we know about tubulinopathies. Tubulinopathies, as some of you may be knowing, are associated with like dysmorphic basal ganglia, associated with cortical malformations. But in this case, it is not associated with cortical malformations. Rather, it is associated with hypomyelination with atrophy of the basal ganglia and cerebellum. Apart from that, there are certain other mutations also. For example, UFM1 mutations in which this basal ganglia atrophy may not be as prominent as is seen with TUP4A gene mutations. So these patients, because of the basal ganglia predominant involvement, there is lot of dystonias, extrapyramidal symptoms. And what do we see is basal ganglia atrophy, disappearing basal ganglia, and there may be associated lobus pallidus hypointensity as well, in addition to cerebellar atrophy. So, this is another case taken from literature. In this, we see, apart from diffuse, mildly hyperintense signal, we see very hypointense signal of the basal ganglia of the globus pallidus. On SWI, we are seeing that there is pairing of the medullary lamina of the globus pallidus. And in addition, what provides the clue? Very good. So, it is a case of fucocytosis. So, what provides the clue is there is presence of certain skeletal abnormalities. So there are skeletal dysostosis, and this is a case of fucocytosis in which we see a pattern which may not be seen in all cases, but when we see it can provide a clue. So in this globus pallidus, hypointensity will be there, but there will be alternating hyperintensities within the globus pallidi. So this is again a storage disorder. So there will be associated hepatosplenomegaly, cardiomegaly, but these patients also have skeletal abnormalities as well as can have skin abnormalities like angiokeratoma, diffusum corporis. And on MR, apart from diffuse hypomyelination, we see there is this alternating hyperintense signal in the globus pallidus, and there can be associated skeletal and skin abnormalities, which provides the clue. So, till now, we have discussed the other pattern, which was hypomyelination with involvement of the basal ganglia. Now we saw many of the cases already in which there was presence of T2 hypointense thalami. So we saw in polar 3-related leukodystrophy, there may be hypointense signal of the ventrolateral thalami. Apart from that, storage disorders like fucosidosis we saw, GM2 gangliosidosis we saw, and now we'll see another case of neuronal spheroid lipofuscinosis. So this is a case of NCL. Actually, I wanted to ask the case, but I told the diagnosis. So in this is again a secondary hypomyelitic leukodystrophy. So these children have usually very severe symptoms. They have myoclonus, they have seizures. And what do we see on MR is there is significant atrophy of the cerebral hemispheres as well as cerebellar hemispheres, as well as the thalami may appear mildly hypointense in signal. And apart from that, how do we see hypomyelination is we see very small periventricular white matter hyperintensity, sometimes not always, but when present, they are actually pathologically found to be hypomyelinating. So it is a secondary hypomyelitic leukodystrophy. It is basically a neurodegenerative disorder where there is marked atrophy of the cerebral and cerebellar hemispheres, which is out of proportion to the hypomyelination seen in them. So whenever we are encountering T2 hypointense thalami, so it is just one short algorithm which may be helpful sometimes. So look at the basal ganglia. So whenever there is presence of hyperintense basal ganglia and we see preserved corpus callosum, the diagnosis can be GM1, GM2 gangliosidosis, of course with certain clinical features like cherry red macula, hepatosplenomegaly, coarse faces. If no, then look at globus pallidus. If it is T2 hypointense globus pallidus, and there is presence of alternating hyperintensities, it can be fucosidosis. Again, we have to look at clinical clues. If it is not there, it may be just a case of polar 3-related leukodystrophy, and then we look at the white matter. There can be selective sparing of the white matter. And apart from that, this hypointense globus pallidus may or may not be present, but if there is involvement of the like there is significant atrophy of the basal ganglia, it may be a case of HABC. So whenever there is T2 hypointense thalami, in case of hypomyelitic leukodystrophy, try to look at the basal ganglia, and depending upon whether it is hyperintense, whether there is GP hypointensity, or whether there is significant atrophy of the basal ganglia, we can provide a clue towards the diagnosis. Then we have, as we already saw many cases like HABC, polar 3-related leukodystrophy. We can have certain other disorders as well, where cerebellar atrophy is a predominant feature along with hypomyelination. One of them is 18q deletion syndrome. So in this, we see mild hypomyelination, but we see multi-organ anomalies, and we can also see inner anomalies in these patients. And then there's a very rare disorder which is known as ODD, which is actually oculodentodigital dysplasias. In this, in addition to the hypomyelination, we can see certain dental abnormalities. There can be digital abnormalities and ocular abnormalities. So in these cases, clinical clues provide the diagnosis in addition to hypomyelination. There can be certain other features like cerebellar atrophy as well as calcifications in these cases. And cerebellar atrophy again was a predominant feature in LCL, as we already saw, and Cohen syndrome, which we'll see in the subsequent slide. So whenever we are seeing cerebellar atrophy on with hypomyelination, look for calcifications. If calcifications are present, there are certain differentials, which we'll see in the subsequent slide. And if calcification is not present, if there is significant atrophy of the basal ganglia, it can be HABC. If calcification is not present, but there are multi-organ anomalies, there can be 18q deletion syndrome. So then we have hypomyelination with brainstem involvement, as we already discussed about PMLD, where, so this is a diagrammatic to represent PMD, where there was sparing of the ventral brainstem except for the corticospinal tract, as compared to PMLD, where there was diffuse involvement of the both ventral and dorsal brainstem. Then there can be brainstem involvement in HEMS, as we saw that early involvement of the posterior brainstem, and apart from that, ODD can also have. And apart from that, there is one specific diagnosis as we saw in LBSL. So similar to Cook
Recording in
syndrome has
progress.
certain clinical features which can provide a lot of clue for the diagnosis. For example, these patients can have cutaneous photosensitivity, progeroid faces, retinal pigmentary abnormalities. These can have dental caries. But what important pattern we should remember on MR is, apart from diffuse hypomyelination, there is presence of calcifications. Now, these calcifications are usually homogeneous, involving the putamina, but in severe cases, they can also involve the depth of the sulci as well. And these calcifications may not be present at the outset, especially if the child is less than years of age. On SWI, we may sometimes not calcifications, but if